We are analyzing three critical perioperative domains today: the hypermetabolic crisis of malignant hyperthermia, the neurochemical pathways of perioperative nausea and vomiting, and the pharmacokinetic interferences introduced by botanical supplements and cannabis. This review is engineered for high-stakes intraoperative application and CRNA board preparation. We are isolating the exact testable mechanics that dictate clinical action. Every pathology we cover will be deconstructed through a specific framework: its underlying cellular mechanism, its quantitative risk stratification, and its precise pharmacological blockade. The operating room requires the real-time synthesis of disparate, rapidly changing data points. You must identify failing physiological systems and deploy targeted chemical interventions to stabilize them. Clinical mastery relies on understanding how specific receptor mutations and neural pathways explicitly define your choice of anesthetic drug. Malignant hyperthermia, or MH, is an autosomal dominant hereditary disorder affecting skeletal muscle. It presents clinically as a sudden, life-threatening hypermetabolic state. The epidemiological incidence is heavily skewed. It occurs in 1 out of every 30,000 children, compared to 1 in 100,000 adults. Males are 2.5 to 4.5 times more likely to be affected than females. The core physiological defect is a mutation in the ryanodine receptor, or RYR1, which regulates the release of calcium from the sarcoplasmic reticulum. Two specific classes of drugs act as triggers for this mutation: halogenated inhalational anesthetics like sevoflurane, desflurane, and isoflurane, and the depolarizing muscle relaxant succinylcholine. Exposure to these triggering agents causes an uncontrolled flood of calcium ions from the sarcoplasmic reticulum directly into the muscle cytoplasm. This flowchart tracks the resulting metabolic cascade. The increased intracellular calcium forces sustained muscle contraction, which generates high volumes of lactic acid and heat, driving a massive spike in oxygen consumption and carbon dioxide production. In the operating room, tachycardia and a rapidly rising end-tidal CO2 are the earliest measurable clinical indicators of this hypercarbic state. Hyperthermia is a late-stage indicator. A patient's temperature will climb rapidly, rising 1 to 2 degrees Celsius every 5 minutes, frequently reaching an average of 39.3 degrees Celsius. Because the generation of heat occurs at the end of the metabolic cascade, relying on temperature changes delays intervention. Monitor-based signs like end-tidal CO2 provide your only window for early rescue. When an MH crisis triggers, immediate action is required. Discontinue all volatile anesthetics and succinylcholine. Alert the surgical team and call the MH hotline at 1-800-644-9737 for expert guidance. This schematic details mechanical adjustments to your anesthesia machine. Flush the system with 100% oxygen at 10 liters per minute. Change the carbon dioxide absorbent, install new circuits, and place activated charcoal filters on both inspiratory and expiratory limbs. Dantrolene is the primary antidote and the only drug specifically approved to treat MH. It acts as an RYR1 antagonist, inhibiting the release of calcium ions from the sarcoplasmic reticulum. This data chart contrasts the available dantrolene formulations. Standard 20 mg vials like Dantrium or Revanto contain 3 grams of mannitol and require 60 milliliters of diluent. Ryanodex comes in 250 mg vials containing 0.125 grams of mannitol, requiring only 5 milliliters of diluent. You must reconstitute dantrolene exclusively with sterile water. Never use sodium chloride. The initial dantrolene dose is 2.5 milligrams per kilogram IV. Concurrently, institute hyperventilation with 100% oxygen and treat hyperkalemia aggressively using insulin with glucose and sodium bicarbonate. If the patient develops cardiac dysrhythmias, administer amiodarone. Calcium channel blockers are strictly contraindicated during an MH crisis. Following stabilization, the patient requires transfer to an ICU for at least 24 hours of continuous monitoring to watch for recurrence and must be registered with the North American Malignant Hyperthermia Registry. Surviving an MH crisis depends on 3 distinct variables: the speed of initial recognition, the speed of machine isolation, and the speed of high-dose dantrolene administration. Postoperative nausea and vomiting, or PONV, affects 30 to 40% of all patients undergoing general anesthesia, leading to delayed discharges, wound dehiscence, and aspiration pneumonia. Vomiting is a coordinated physical expulsion initiated by antiperistalsis in the upper GI tract, followed by glottis closure, and finalized by the forceful contraction of the diaphragm and abdominal wall muscles. This medulla diagram maps the vomiting center and the chemoreceptor trigger zone. Specific receptors mediate arriving signals. The GI tract uses 5-HT3 and NK1. The vestibular system uses H1 and M1. The trigger zone integrates D2, 5-HT3, and NK1. The APFL simplified risk score isolates 4 primary patient variables for adults: female gender, non-smoker status, a history of PONV or motion sickness, and the planned use of postoperative opioids. Each variable increases the statistical probability of PONV. 0 risk factors presents a 10% baseline incidence. The probability scales up by roughly 20% per factor, reaching an 80% likelihood for a patient exhibiting all 4. Pediatric risk scoring operates on a different matrix. High-risk indicators include surgeries lasting longer than 30 minutes, or specific procedures like strabismus repair and adenotonsillectomies. The vomiting reflex is a sum of varying neurological inputs. Prophylaxis requires targeted antagonism of multiple receptor classes simultaneously, scaled directly to the patient's calculated risk score. 5-HT3 receptor antagonists, like ondansetron and granisetron, work by blocking serotonin release from enterochromaffin cells in the GI tract, preventing vagal afferent stimulation. While the standard adult dose of ondansetron is 4 mg, granisetron offers a distinct pharmacokinetic advantage. Its 9-hour elimination half-life makes it highly effective for outpatient surgeries requiring prolonged coverage. Corticosteroids like dexamethasone provide a potent anti-inflammatory effect. However, a single 4 to 8 mg IV dose carries a proven risk of perioperative hyperglycemia, requiring caution in diabetic or obese patients. Dopamine receptor antagonists, specifically droperidol and metoclopramide, target D2 receptors directly in the chemoreceptor trigger zone. Droperidol carries a boxed warning for QT prolongation. Metoclopramide stimulates upper GI motility, but introduces a risk of extrapyramidal reactions and akathisia due to CNS dopamine antagonism. For vestibular triggers and motion sickness, the anticholinergic scopolamine provides sustained plasma concentrations. The transdermal patch must be applied at least 4 hours before the noxious stimulus to reach peak prophylactic effect. NK1 antagonists like aprepitant block substance P in the brainstem. Due to their high cost, they are generally reserved for the highest risk patients or procedures where postoperative vomiting would compromise surgical repair. If prophylaxis fails, you must follow the rescue rule. Treat established PONV promptly using a completely different pharmacological class than the agents administered for prevention. Non-pharmacologic interventions can serve as adjuncts. Evidence supports adequate hydration, ginger, and acupuncture as effective complementary strategies. For high-risk patients with 3 or more APFL factors, optimal management combines multiple prophylactic agents with total intravenous anesthesia, entirely eliminating the emetic triggers of volatile inhaled gases. Approximately 25% of patients use alternative therapies. Because they bypass FDA approval for safety and efficacy, they introduce unpredictable drug interactions into the perioperative window. The G supplements, garlic, ginger, ginkgo biloba, and ginseng, all share a high-yield clinical risk. They increase bleeding tendencies and interact dangerously with warfarin. This timeline plots the required discontinuation dates prior to elective surgery. Garlic, ginger, and ginseng must be stopped 7 days out. Ginkgo biloba requires a 36-hour cessation period. St. John's wort acts as a potent inducer of cytochrome P450 enzymes. It dramatically accelerates the metabolism of concurrent medications and blocks serotonin reuptake. It must be discontinued 5 days before surgery to prevent serotonin syndrome. Supplements used for anxiety and sedation, namely kava kava and valerian, produce additive physiological effects when combined with benzodiazepines and intravenous anesthetics. Cannabis remains the most commonly used illicit drug globally, maintaining classification as a Schedule I substance under the DEA, despite widespread medicinal use across states. Administration route dictates pharmacokinetics. Inhalation provides onset within seconds to minutes. Oral ingestion of edibles delays the onset by up to 120 minutes due to heavy first-pass hepatic metabolism. The active components function as partial agonists. CB1 receptor activation in the central nervous system yields anti-nociception and altered cognition. CB2 receptor activation decreases peripheral inflammation. Intraoperatively, chronic cannabis use increases the risk of airway hyperreactivity. Patients demonstrate cross-tolerance to sevoflurane, requiring a higher minimum alveolar concentration for anesthesia, and consistently exhibit elevated postoperative pain scores. Botanicals and cannabis operate as pharmacologically active substances, requiring strict anesthetic adjustments, including altered dosing profiles and prolonged cessation timelines. To synthesize, an active malignant hyperthermia crisis shows an early rise in end-tidal CO2, with hyperthermia manifesting last. Treat immediately with 2.5 milligrams per kilogram of dantrolene, reconstituted solely with sterile water. For PONV, quantify the risk using the APFL score to dictate the number of prophylactic drug classes required. If nausea breaks through, rescue with an entirely different receptor antagonist. Stop the G supplements 7 days before an incision, except ginkgo at 36 hours. Halt St. John's wort at 5 days, and prepare for increased anesthetic requirements in regular cannabis users. This model illustrates the intersection of pharmacology and patient physiology. Every drug binds to a specific receptor with a calculated half-life and known side effect profile. By mastering the precise cellular mechanics of these domains, you ensure the safety of your patient by anticipating and neutralizing physiological crises long before they happen.